Question 1. An emergency medical technician, EMT, leaves a patient who is awaiting care in the emergency department lobby without providing a verbal report to the receiving nurse or physician. This situation would most likely be considered A. Assault, B. Battery, C. Abandonment, D. Breach of confidentiality. Answer: C. Abandonment. This question tests the essential legal concept of abandonment, which is leaving a patient who requires care without securing an appropriate alternative provider. The keyword clue is leaves a patient without providing a verbal report, which highlights the failure to properly transfer responsibility. Abandonment occurs when an EMT initiates care, but then terminates it without ensuring the patient is turned over to personnel of equal or higher training. For example, simply dropping a patient off at the triage desk and driving away before a nurse accepts the report is a clear act of abandonment. Always remember that proper patient handoff, which includes a verbal report, must happen before your duty to act is considered fulfilled. Question 2. A 67-year-old male is in cardiac arrest. After confirming unresponsiveness and absence of breathing/pulse, the primary EMT should start ventilating the patient via a bag valve mask, BV, at a rate of A. 10 to 12 breaths per minute, B. 6 to 8 breaths per minute, C. 20 to 24 breaths per minute, D. 1 breath every 3 to 5 seconds. Answer: A. 10 to 12 breaths per minute. This question assesses the proper ventilation rate for an adult in cardiac arrest, a critical component of basic life support, BLS. While doing compressions, the standard rate for ventilations with an advanced airway or during CPR should be 10 to 12 breaths per minute, which equates to 1 breath every 5 to 6 seconds. The lower rate of 6 to 8 breaths per minute is often used for pediatric patients or in specific advanced scenarios, but not for the standard adult arrest scenario. Overventilating a patient is dangerous because it can cause gastric distension and decrease the blood return to the heart, thus lowering the effectiveness of chest compressions. Remember to deliver gentle breaths that cause the chest to visibly rise and fall, ensuring you do not hyperventilate the patient. Question 3. A 45-year-old construction worker fell 20 feet from a scaffold. On arrival, he is responsive only to pain, has labored breathing, absent breath sounds on the right, and his trachea is visibly shifted to the left. These findings are most indicative of A. Flail chest, B. Pulmonary contusion, C. Hemothorax, D. Tension pneumothorax. Answer: D. Tension pneumothorax. This item tests the recognition of a life-threatening, obstructive shock condition known as tension pneumothorax. The keyword clues are absent breath sounds on one side combined with trachea is visibly shifted, tracheal deviation, following a significant trauma. A tension pneumothorax occurs when air enters the chest cavity but cannot escape, causing pressure to build up, which eventually pushes the mediastinum, including the trachea and heart, to the opposite side. While an EMT cannot perform the definitive treatment, recognizing this immediate life threat allows for rapid transport and notification of the receiving facility. Here is an easy way to remember it. Absent breath sounds plus jugular vein distension, JVD, or tracheal deviation equals life-threatening pressure or tension. Question 4. An unresponsive 34-year-old patient has a rapid, weak pulse, cool and clammy skin, and medical jewelry indicating she is diabetic. The EMT's initial treatment should involve A. Assessing blood glucose, then administering oral glucose if the patient can swallow. B. Placing the patient in the recovery position and administering high-flow oxygen. C. Establishing an airway and administering a glucagon injection if protocols allow and train. D. Establishing an airway, ensuring adequate ventilation, and providing immediate transport. Answer: D. Establishing an airway, ensuring adequate ventilation, and providing immediate transport. This scenario assesses the crucial initial management of an unresponsive patient, prioritizing the ABCs over specific treatments. Because the patient is unresponsive, she cannot protect her own airway, making administration of oral glucose or even an intramuscular injection secondary to ensuring adequate ventilation and rapid transport. The most immediate life-saving interventions for any unresponsive patient are airway control and ventilatory support, followed by urgent transport, especially since the EMT cannot administer 4-dextrose. For example, trying to administer oral glucose to an unresponsive patient risks aspiration, which is a significant complication. Always remember that an altered mental status compromises the patient's airway protection and always requires immediate attention to the ABCs and rapid transport. Question 5. The EMT is preparing to administer aspirin to a patient experiencing chest pain. A contraindication to administering aspirin would be A. History of previous myocardial infarction. B. Low blood pressure, hypotension. C. Known allergy to non-steroidal anti-inflammatory drugs, NSAIDs. D. Administration of nitroglycerin within the last 5 minutes. Answer. C. Known allergy to non-steroidal anti-inflammatory drugs, NSAIDs. This question tests a core pharmacology concept, specifically the contraindications for administering aspirin in the field for suspected cardiac chest pain. A contraindication is a reason you should absolutely not give a medication, and a known allergy to the drug or related drugs, like NSAIDs, is an absolute bar to administration. Aspirin is given because it is an antiplatelet medication that prevents further blood clot formation in the heart's arteries, but an allergy could trigger anaphylaxis, a life-threatening allergic reaction. Neither hypotension nor recent nitroglycerin use are contraindications for aspirin, and a prior heart attack is actually an indication. Always ensure you check for patient allergies before administering any medication to prevent a serious, potentially fatal, allergic reaction. Question 6. A patient who is alert and oriented reports difficulty breathing and displays orthopnea and pedal edema. These findings are most consistent with A. Spontaneous pneumothorax. B. Asthma exacerbation. C. Congestive heart failure, CHF. D. Diabetic ketoacidosis. D. Answer. C. Congestive heart failure, CHF. This scenario tests the recognition of key signs and symptoms associated with congestive heart failure, CHF. The crucial clinical clues are orthopnea, which is difficulty breathing when lying flat, and pedal edema, which is swelling in the feet and ankles, both resulting from the heart's inability to effectively pump fluid. These signs indicate fluid backup in the lungs, pulmonary edema, and peripheral tissues, a hallmark of heart failure. While the other conditions involve breathing difficulty, they do not typically present with this specific combination of fluid-related symptoms. When you see breathing difficulty plus fluid retention signs like JVD or swelling, think of a pump problem, which is what CHF fundamentally is. Question 7. Upon arriving at the scene of a motor vehicle collision, your first and most critical action is to A. Conduct a primary assessment of the most critical patient. B. Request additional resources like fire department or police. C. Establish scene safety by completing a 360-degree assessment. D. Access the patient and apply cervical spinal immobilization. Answer. C. Establish scene safety by completing a 360-degree assessment. This question addresses the fundamental principle of emergency medical operations and scene management. Scene safety. The keywords first and most critical action immediately point to the need to ensure the crew and patient are not endangered before any clinical care begins. You cannot help the patient if you become a patient, so a thorough scene survey for hazards like traffic, downed wires, or violence must be completed first. For example, if there is spilled gasoline, the EMT must wait for the fire department to secure the scene before approaching. Always remember the priority hierarchy. Scene safety is always first, followed by the patient's well-being, which is often summarized as safety first, patient second. Question 8. When using the Pediatric Assessment Triangle, the appearance component assesses
A.
Skin color and temperature.
B.
Work of breathing.
C.
Muscle tone and interactivity.
D.
Respiratory rate and heart rate. Answer: C. Muscle tone and interactivity. This question assesses knowledge of the Pediatric Assessment Triangle, PAT, a rapid, hands-off tool used to form a first impression of a sick child. The appearance component is a snapshot of the child's neurological status and general interaction, specifically looking at their tone, interactiveness, consolability, look/gaze, and speech/cry. This tells the EMT how the child is engaging with the environment, which is a strong indicator of the severity of illness. For example, a child who is limp, poor tone, and not making eye contact, poor interactiveness, is much sicker than one who is crying vigorously. Remember that the PAT is a visual tool only and never involves touching the patient, which makes the appearance component a quick gauge of the child's overall neurological status. Question 9. A 28-year-old female reports severe, sharp pain in the lower right quadrant of her abdomen and states she missed her last period. She is alert, but her skin is pale and slightly diaphoretic. The EMT should immediately suspect
A.
Appendicitis.
B.
Kidney stone.
C.
Ectopic pregnancy.
D.
Pelvic inflammatory disease, PID. Answer: C. Ectopic pregnancy. This scenario tests the critical recognition of a potentially life-threatening gynecological emergency, specifically an ectopic pregnancy. The combination of severe, sharp pain in a lower quadrant and the key phrase, missed her last period, in a female of childbearing age should immediately raise the suspicion of an ectopic pregnancy rupture, where the fertilized egg implants outside the uterus. While appendicitis and PID can cause lower quadrant pain, the element of a missed period signals a high risk of internal hemorrhage from a ruptured ectopic pregnancy. It is vital to recognize this because internal bleeding can quickly lead to hypovolemic shock. Always consider ectopic pregnancy in any female patient of childbearing age presenting with lower abdominal pain and signs of shock, even if subtle. Question 10. A 72-year-old male with severe bleeding from a laceration is pale, cool, and diaphoretic, with a heart rate of 120 beats per minute, BPM, and blood pressure, BP, of 130 over 85 mmHg. This presentation is classified as
A.
Decompensated shock.
B.
Compensated shock.
C.
Irreversible shock.
D.
Distributive shock. Answer: B. Compensated shock. This question evaluates the understanding of the stages of shock, particularly compensated shock. The defining feature in this scenario is that the patient's body is attempting to maintain normal perfusion by keeping the blood pressure, BP, within a normal range, 130/85 mmHg, despite significant blood loss, as indicated by the classic signs of pallor, cool skin, and a rapid pulse, tachycardia. In compensated shock, the heart rate increases and blood vessels constrict to maintain the BP. The shift to decompensated shock is marked by a drop in blood pressure, hypotension, which is not present here. Recognize that a normal blood pressure in a patient showing other signs of shock is a sign that the body is working hard and the condition is severe, necessitating immediate treatment and rapid transport. Question 11. The proper technique for inserting an oropharyngeal airway, OP, in an adult patient involves
A.
Inserting it right side up until it reaches the soft palate.
B.
Inserting it upside down and rotating it 180 degrees once the tip reaches the hard palate.
C.
Inserting it sideways and rotating it 90 degrees as it passes the tongue.
D.
Inserting it upside down and rotating it 90 degrees once the tip is in the mouth. Answer: B. Inserting it upside down and rotating it 180 degrees once the tip reaches the hard palate. This question tests the essential technique for safely inserting an oropharyngeal airway, OP, in an adult patient to ensure an open airway. The OPA must be inserted upside down to avoid pushing the tongue back and obstructing the airway further. Once the tip of the airway reaches the hard palate, the EMT rotates the device 180 degrees, which correctly positions the flange, the flat part, at the patient's lips and moves the curved section over the tongue, pulling it forward. This rotation technique is designed to clear the tongue from the posterior pharynx, which is the most common cause of airway obstruction in the unresponsive patient. For pediatric patients, the device is usually inserted right side up using a tongue depressor to avoid trauma to the hard palate. Question 12. A patient with a history of severe chronic obstructive pulmonary disease may rely on a hypoxic drive to stimulate breathing. This means their respiration is stimulated by
A.
Low carbon dioxide levels in the blood.
B.
High carbon dioxide levels in the blood.
C.
Low oxygen levels in the blood.
D.
High oxygen levels in the blood. Answer: C. Low oxygen levels in the blood. This question explores the unique pathophysiology of breathing in patients with end-stage chronic obstructive pulmonary disease, focusing on the concept of hypoxic drive. Normally, the body regulates breathing primarily based on high carbon dioxide levels, but in severe COPD, the body becomes desensitized to chronically high CO2. Therefore, these patients begin to rely on persistently low oxygen levels hypoxemia to stimulate their breathing. Giving excessive high-flow oxygen can, in rare cases, remove this low oxygen stimulus, theoretically causing the patient to slow or stop breathing. While it is rare, it is crucial to administer oxygen carefully to COPD patients, aiming for a saturation of 88 to 92% and titrating to effect, though high-flow oxygen should still be given to anyone in severe respiratory distress. Question 13. A conscious, mentally competent 65-year-old patient who refuses care from the EMTs and signs a refusal form is exercising which type of consent?
A.
Implied consent.
B.
Expressed consent.
C.
Involuntary consent.
D.
Minor's consent. Answer: B. Expressed consent. This item tests the legal concept of express consent in the context of a patient's right to refuse treatment. Express consent, also called actual consent, is when a patient verbally or non-verbally authorizes medical care, and in this case, the refusal of care is an explicit decision made by a competent adult. Implied consent is used when a patient is unconscious or otherwise incapacitated and cannot give explicit permission, and the law presumes they would want life-saving care. The key clue here is that the patient is conscious and mentally competent and signs a refusal form, demonstrating a clear, explicit decision. Always ensure you thoroughly document the patient's refusal, your assessment of their competency, and the risks you explain to them. Question 14. During the patient assessment, the first component completed immediately after the scene size-up is the
A.
History taking, sample/OPQRST.
B.
Primary assessment, identify and treat immediate life threats.
C.
Detailed physical exam, head-to-toe or focused exam. D. Reassessment, checking interventions and vital signs. Answer: B. Primary assessment, identify and treat immediate life threats. This question focuses on the correct sequential order of the patient assessment process. The primary assessment must always follow the scene size-up and is the critical step used to quickly identify and manage immediate, life-threatening conditions, particularly issues with the airway, breathing, and circulation, ABCs. This rapid process, which should be completed within 60 to 90 seconds, dictates whether the patient is a load-and-go, trauma, or a stay-and-play medical patient. Neither the detailed exam nor history taking should occur before immediate life threats are controlled. Remember this sequence: scene size-up, primary assessment, history, secondary assessment, and reassessment. Question 15. The primary therapeutic effect of nitroglycerin in patients experiencing chest pain is
A.
To directly lower the heart rate and blood pressure.
B.
To increase the heart's oxygen demand by contracting the coronary arteries.
C.
To cause vasodilation, reducing the workload of the heart.
D.
To prevent the aggregation of platelets, thinning the blood. Answer: C. To cause vasodilation, reducing the workload of the heart. This question assesses the main pharmacological action of nitroglycerin, a critical drug for cardiac chest pain. Nitroglycerin is a potent vasodilator, meaning it causes blood vessels to widen, which reduces the resistance against which the heart has to pump blood, known as preload and afterload. This reduction in the heart's workload decreases its oxygen demand and can alleviate chest pain caused by ischemia, lack of oxygen. The keywords therapeutic effect point to the desired outcome, which is not blood thinning or direct rate control, but rather reducing cardiac workload. Keep in mind that vasodilation also lowers blood pressure, so it is contraindicated if the patient is hypotensive. Question 16. A patient who opens their eyes to a verbal command, speaks confusedly, and localizes pain would receive what total Glasgow Coma Scale? G's score?
A. 12. B.
10.
C.
14.
D. 9.
Answer: A. 12. This question tests the correct calculation of a Glasgow Coma Scale, GCS, score, an essential tool for quantifying level of consciousness. The score is determined by adding the points from 3 categories: eye-opening, E, verbal response, V, and motor response, M. In this case, eyes open to verbal command is 3 points, speaking confusedly is 4 points, and motor response to localizes pain is 5 points. The total GCS score is 3 plus 4 plus 5, which equals 12. A score of 15 is the highest, alert, and normal, while a score of 3 is the lowest, deep coma or death, so a GCS of 12 indicates a moderate level of impairment. Question 17. A 35-year-old jogger collapsed. His skin is hot and dry, he is unresponsive, and his core temperature is significantly elevated. This presentation is most consistent with
A.
heat exhaustion,
B.
heat stroke,
C.
hypothermia,
D.
diabetic ketoacidosis. DICA? Answer: B. heat stroke. This question asks the student to differentiate between the 2 major heat emergencies, focusing on the defining characteristics of heat stroke. The critical findings here are hot and dry skin and an unresponsive mental status, which signal a failure of the body's thermoregulatory system. In contrast, heat exhaustion presents with cool, clammy, and diaphoretic, sweaty skin, and the patient is usually still alert. Heat stroke is a true medical emergency where the body's core temperature is dangerously high, leading to central nervous system dysfunction. The immediate treatment involves aggressively cooling the patient while managing their airway and breathing. Question 18. An EMT is treating a patient experiencing a severe allergic reaction, anaphylaxis, with profound wheezing and hypotension. The medication of choice is
A.
oral diphenhydramine Benadryl,
B.
inhaled albuterol,
C.
subcutaneous epinephrine,
D.
oral aspirin. Answer: C. subcutaneous epinephrine. This question assesses the proper pharmacological intervention for a life-threatening anaphylactic reaction in the EMT scope of practice. The presence of profound wheezing, respiratory distress, and hypotension shock indicates a systemic, severe allergic reaction. Epinephrine is the medication of choice because its properties as a vasoconstrictor raise the blood pressure and its bronchodilator properties open the airway, immediately reversing the life-threatening effects. While albuterol helps with wheezing, it does not treat the low blood pressure, and Benadryl is too slow-acting for an acute emergency. Always carry and be prepared to administer epinephrine auto-injectors rapidly to any patient displaying signs of a severe allergic reaction. Question 19. During a multiple casualty incident, MCI, TRIA, a patient who is unresponsive, apneic after airway repositioning, and has no pulse should be classified with what triage tag color?
A.
Red, immediate.
B.
Yellow, delayed.
C.
Green, minor.
D.
Black, deceased/expectant. Answer:
D.
Black, deceased/expectant. This item tests knowledge of triage classification, specifically for a patient who is beyond immediate help in a mass casualty incident where resources are limited. The key finding is the patient being unresponsive and remaining apneic after airway repositioning, which confirms an unsalvageable condition using simple, rapid interventions. Triage protocols like START dictate that if a patient does not begin breathing after opening the airway, they are tagged as black, meaning their chance of survival is extremely low given the need to prioritize resources for patients with higher survivability. Remember that during triage, resources must be allocated to the greatest good for the greatest number of people, which means setting aside patients unlikely to survive. Question 20. The primary muscle of breathing, the one responsible for the majority of the work of ventilation, is the
A.
intercostal muscles,
B.
pectoralis muscles,
C.
diaphragm,
D.
accessory muscles. Answer:
C.
diaphragm. This question tests basic respiratory anatomy and the physiology of normal breathing. The diaphragm is the large, dome-shaped muscle located at the base of the chest cavity, and its contraction is the primary mechanism that initiates inhalation by expanding the volume of the chest. When the diaphragm contracts, it moves downward, creating a negative pressure in the chest that pulls air into the lungs. The intercostal and accessory muscles assist with breathing, but they are not the main driver of quiet, resting ventilation. Recognizing the role of the diaphragm is critical when assessing patients for signs of respiratory failure, as other muscles must take over when it is fatigued. Question 21. When completing a patient care report (PCR) after call, the most important reason for accurate and thorough documentation is to
A.
ensure the agency receives proper billing,
B.
provide a legal record of the care provided,
C.
satisfy state regulatory requirements, D. allow for statistical analysis of injury patterns. Answer: B. Provide a legal record of the care provided. This question emphasizes the paramount importance of documentation in emergency medical services, EMS. While all the options are valid reasons for a PCR, the most important is that the report serves as the primary legal document detailing the assessment and interventions performed by the EMT. This legal record is essential for continuity of care at the receiving facility, but also crucial for protecting the EMT in case of litigation or for auditing the quality of care. For example, if a treatment is not documented, legally it is considered to have never been performed. Therefore, make sure to document all findings, treatments, and refusals completely and accurately because your PCR speaks for you in court. Question 22. In a patient with an advanced airway in place, the EMT uses waveform capnography and notes a reading of 50 millimeters of mercury. This value, ETCO2, indicates
A.
normal ventilation,
B.
hyperventilation,
C.
hypoventilation,
D.
hyperoxygenation. Answer: C. hypoventilation. This question tests the interpretation of end-tidal carbon dioxide, ETCO2, values, a critical skill often incorporated into EMT and paramedic protocols. Normal ETCO2 levels are generally between 35 and 45 millimeters of mercury, which reflects the amount of carbon dioxide being expelled from the body. A reading of 50 millimeters of mercury is above the normal range, indicating that the patient is retaining too much carbon dioxide, which is a sign of hypoventilation, too shallow, or too slow breathing. For example, if a patient is oversedated, their breathing may slow, causing CO2 to build up and the ETCO2 value to rise. A high ETCO2 reading should prompt the EMT to increase the rate or depth of ventilations immediately. Question 23. You are assessing an 82-year-old patient who takes 7 different prescription medications daily. You must be aware of the increased risk of
A.
drug tolerance,
B.
polypharmacy,
C.
addiction,
D.
withdrawal syndrome. Answer: B. Polypharmacy. This question focuses on a major issue in geriatric care called polypharmacy. The keyword 7 different prescription medications points directly to the definition of polypharmacy, which is the simultaneous use of multiple drugs by a single patient. This practice significantly increases the risk of adverse drug interactions, side effects, and complications because of how various drugs interact within the body. When assessing an elderly patient, it is vital to obtain a full list of all medications, including over-the-counter drugs, to help the hospital staff identify potential drug interactions. Understanding the patient's medication regimen is crucial for identifying the cause of an altered mental status or other uncharacteristic symptoms. Question 24. To quickly assess a patient for a possible stroke, the EMT uses the Cincinnati Pre-Hospital Stroke Scale. The 3 components of the scale are
A.
speech, extremity movement, and pupil reaction.
B.
Facial droop, arm drift, and abnormal speech.
C.
Level of consciousness, respiratory rate, and heart rate.
D.
Headache severity, visual disturbance, and arm drift. Answer: B. Facial droop, arm drift, and abnormal speech. This question tests the components of the widely used Cincinnati Pre-Hospital Stroke Scale, a rapid assessment tool designed to quickly identify the signs of an acute stroke in the pre-hospital setting. The 3 key signs are facial droop, ask the patient to smile; arm drift, ask the patient to hold both arms out with palms up; and abnormal speech, ask the patient to repeat a simple phrase. The acronym FAST, facial droop, arm drift, speech difficulty, time to call 911, is an easy way to remember these components and the urgency of the situation. Time is crucial in stroke treatment, so identifying and documenting a positive score for any of these signs is vital for ensuring rapid transport to a stroke center. Question 25. A patient involved in a high-speed motor vehicle collision presents with severe, isolated pain over the pelvis and signs of hypovolemic shock. The EMT must immediately recognize the high risk of
A.
tracheal deviation,
B.
significant internal hemorrhage,
C.
cardiac tamponade,
D.
subcutaneous emphysema. Answer: B. significant internal hemorrhage. This question tests the recognition of the severe, hidden consequences of pelvic fractures, a common injury following high-mechanism trauma. The combination of severe, isolated pain over the pelvis and signs of hypovolemic shock is a massive red flag because the pelvis can hold a large volume of blood, up to several liters, from damaged blood vessels, leading to profound internal hemorrhage. Neither tracheal deviation nor subcutaneous emphysema is typically associated with a closed pelvic fracture. The key action for the EMT is to use a pelvic binder or sheet to stabilize the fracture and attempt to reduce the internal bleeding by stabilizing the bony fragments and applying pressure. Question 26. A patient in moderate to severe respiratory distress from congestive heart failure, CHF, may benefit from continuous positive airway pressure, CPAP. The primary mechanism by which CPAP helps this patient is by
A.
providing a high concentration of inhaled oxygen to increase saturation,
B.
forcing fluid out of the alveoli and opening collapsed airways,
C.
increasing the patient's respiratory rate to blow off excess carbon dioxide,
D.
stimulating the central nervous system to take deeper, more controlled breaths. Answer: B. forcing fluid out of the alveoli and opening collapsed airways. This question assesses the function of continuous positive airway pressure, CPAP, a common non-invasive ventilation device used for pulmonary edema, fluid in the lungs, secondary to CHF. CPAP works by pushing air into the lungs at a constant pressure, which effectively forces the fluid that has accumulated in the alveoli, air sacs, back into the pulmonary circulation and prevents the small airways from collapsing. This action improves the surface area for gas exchange, allowing for better oxygenation and ventilation. The device is not just a high-flow oxygen delivery system, but a physical means of supporting the respiratory mechanics. Remember that CPAP helps dry out the lungs and is typically contraindicated in patients who are hypotensive or have a decreased level of consciousness. Question 27. The proper definition of perfusion is
A.
the movement of air in and out of the lungs, ventilation.
B.
The exchange of gases, oxygen and carbon dioxide in the lungs.
C.
The circulation of blood through an organ or tissue, oxygenation and waste removal. D. The mechanical process of the heart pumping blood throughout the body. Answer: C. The circulation of blood through an organ or tissue, oxygenation and waste removal. This question tests the foundational pathophysiological term perfusion, which is central to understanding shock. Perfusion is the critical process of circulating oxygenated blood throughout the body's tissues and organs to deliver nutrients and remove metabolic waste. Adequate perfusion is necessary for all cells to function properly. When perfusion fails, the patient is considered to be in a state of shock. While the other options describe related processes like ventilation and oxygenation, only the complete circulation to the tissue defines perfusion. Therefore, a patient in shock is said to have inadequate perfusion, meaning their tissues are not receiving enough oxygenated blood. Question 28. A 40-year-old construction worker fell 30 feet, landing on his feet. The EMT should immediately suspect potential injuries to the
A.
cervical spine and shoulders,
B.
thoracic spine and rib cage,
C.
lumbar spine and pelvis,
D.
femurs, pelvis and lumbar spine. Answer: D. Femurs, pelvis and lumbar spine. This scenario is a classic example of assessing the mechanism of injury, MOI, specifically axial loading from a fall, which compresses the body upward. When a person lands on their feet from a significant height, the force is transmitted directly up the legs, causing injuries to the feet, ankles, femurs, and, most critically, the pelvis and the lower portion of the spinal column, lumbar spine. Injuries to the head and neck are less likely unless the patient over-rotated or struck an object on the way down. The key takeaway is to trace the path of energy and suspect injuries at every major joint and bony structure along that path, always treating for potential spinal injury. Question 29. A patient with a history of type 1 diabetes presents with deep, rapid respirations and a fruity odor on their breath. This breathing pattern is known as
A.
Cheyne-Stokes respirations,
B.
agonal respirations,
C.
Kussmaul respirations,
D.
Biot's respirations. Answer: C. Kussmaul respirations. This question assesses the recognition of a specific breathing pattern associated with a severe complication of diabetes, namely diabetic ketoacidosis, DIC. The deep, rapid respirations found in a diabetic patient are a compensatory mechanism called Kussmaul respirations, which the body initiates to blow off excess carbon dioxide and thereby reduce the acid levels in the blood, metabolic acidosis. The fruity odor is caused by the patient's body breaking down fat for energy, producing ketones, which are excreted through the breath. This pattern is distinctly different from the irregular, shallow breathing of other patterns. Recognizing Kussmaul respirations is a major clue that the patient requires immediate intervention for a life-threatening acid-base imbalance. Question 30. An EMT is called to the home of a patient with a valid do not resuscitate DNR order who is found pulseless and apneic. The EMT should
A.
begin resuscitation immediately, as DNR orders are not valid in the pre-hospital setting.
B.
Contact medical direction for guidance before initiating or withholding care.
C.
Honor the DNR order and provide comfort care, as per the patient's wishes. D. Begin resuscitation, but cease efforts immediately upon finding the written order. Answer: C. Honor the DNR order and provide comfort care, as per the patient's wishes. This question tests the EMT's understanding of a crucial ethical and legal directive, the Do Not Resuscitate DNR order, which must be immediately honored in the field if it is valid and present. If the patient is pulseless and apneic and a valid, written DNR order is presented, the EMT must not initiate resuscitation efforts and should instead provide comfort care. While protocols vary by state, The key principle is that a legally executed DNR represents the patient's explicit refusal of resuscitative care. It is important to remember that a DNR only applies to resuscitation efforts like CPR and defibrillation and does not mean the EMT should withhold other treatments for pain or comfort. Question 31. When transmitting a radio report to the receiving hospital, the EMT should use
A.
Slang terms and abbreviations to save time.
B.
Clear, concise language and established medical terminology.
C.
The 10 codes specific to the ambulance agency's internal operations.
D.
A casual tone to build rapport with the hospital staff. Answer. B. Clear, concise language and established medical terminology. This question covers the critical skill of effective and professional communication, specifically over the radio to the hospital. A radio report is a concise, standardized summary of the patient's condition and the care provided, so it must be delivered using clear, professional language and accepted medical terminology to avoid confusion. Slang, abbreviations that may not be universal, and internal codes can lead to miscommunication, which could compromise patient care. For example, using the SBR situation, background, assessment, recommendation format ensures a structured and complete report to the receiving facility. Always speak slowly and clearly, and remember that patient information must remain professional and confidential. Question 32. When suctioning the airway of an adult patient, the EMT should limit the duration of suctioning to no more than
A.
5 seconds,
B.
10 seconds,
C.
15 seconds,
D.
20 seconds. Answer. C. 15 seconds. This question addresses the vital airway management skill of suctioning and its safety limitations. To prevent hypoxia, lack of oxygen, and cardiac arrhythmias, suctioning an adult patient should be strictly limited to no more than 15 seconds in a single attempt. Suctioning removes oxygen from the patient's airway along with secretions, so a prolonged period can cause the oxygen saturation to drop dangerously low. For children, the limit is reduced to 10 seconds, and for infants, it is 5 seconds. Remember to pre-oxygenate the patient with 100% oxygen before inserting the suction catheter, and to only apply suction on the way out of the mouth, not on the way in. Question 33. Activated charcoal is indicated in the pre-hospital setting primarily for the treatment of
A.
Carbon monoxide poisoning,
B.
ingested poisonings or drug overdoses,
C.
acute alcohol intoxication,
D.
ingested strong acid or alkali, caustic substances. Answer. B. Ingested poisonings or drug overdoses. This item tests the indications for administering activated charcoal, a common medication for certain ingestions. Activated charcoal works through adsorption, which means the toxins bind to the large surface area of the charcoal in the stomach, preventing the body from absorbing them into the bloodstream. It is primarily used for certain ingested poisons or drug overdoses when given soon after ingestion. It is typically not effective for strong acids/alkalis or hydrocarbons because it doesn't bind well to them, and it is entirely ineffective for carbon monoxide poisoning. The key is that the substance must have been swallowed and still be in the stomach or intestines for the charcoal to be beneficial. Question 34. While driving an ambulance with lights and sirens, an EMT attempts to drive through a large puddle at a high rate of speed. This action increases the risk of
A.
hydroplaning,
B.
engine failure, C. brake fade,
D.
vehicle rollover. Answer. A. hydroplaning. This question covers a critical element of safe emergency vehicle operations, specifically the hazard of hydroplaning. Hydroplaning occurs when the tires lose contact with the road surface because a layer of water builds up beneath them, causing the driver to lose control of steering and braking. Driving at a high rate of speed over a large puddle or wet road significantly increases this risk. For safe operations, the EMT should always slow down when approaching standing water or wet roads to ensure the tires maintain contact and traction with the pavement. Always reduce speed in inclement weather, as the benefits of a faster arrival do not outweigh the risk of losing control of the ambulance. Question 35. A 55-year-old male is in profound shock from internal bleeding. When assessing his radial, femoral, and carotid pulses, the EMT is likely to find
A.
only the radial pulse is absent.
B.
Only the carotid pulse is absent.
C.
All three pulses are likely to be present.
D.
The radial and femoral pulses are absent, but the carotid pulse is present. Answer: D. The radial and femoral pulses are absent, but the carotid pulse is present. This question assesses the relationship between blood pressure, shock severity, and peripheral versus central pulses. As blood pressure drops in profound decompensated shock, the body shunts blood flow to the most vital organs: brain, heart, lungs, and away from the extremities. Consequently, the peripheral pulses, radial and femoral, will often become weak or disappear entirely, while the central pulse, carotid, will usually remain palpable until the patient is in near-terminal arrest. Finding an absent radial pulse but a present carotid pulse is a key clinical sign of significant hypotension and decompensated shock. Always check the most central pulses when you suspect shock to confirm if the patient still has cardiac output.